I think so. We should be good. Thank you. Okay. Well, good morning again, everyone. Whoops. Didn't mean to do that. Hope everyone had as nice an evening as we did last night. So we're going to talk about cardiomyopathy beginning today. And you'll see some tables here. Don't worry, they'll be in the slides. We're not going to go through them in detail. But a new classification of cardiomyopathy has very recently been proposed that's based mostly on etiology. Genetic causes. We know that most hypertrophic cardiomyopathy is genetic. Right ventricular cardiomyopathy, LV non-compaction, and of course other metabolic and those kinds of diseases. Then mixed causes that include dilated and restrictive, and then acquired cardiomyopathies, myocarditis, Takotsubo, peripartum, some of these kind of things. And while this is an interesting and nice classification, I think often for us it's not so practical. I think it's much more practical to look at what we see, and that is the phenotype as it presents, as either hypertrophic or dilated or restrictive. And so I'm going to go through really that way more than with this classification. And what we mean by hypertrophic cardiomyopathy is hypertrophy out of proportion to the load that you can account for. Somebody who doesn't have hypertension or aortic valve stenosis or something like that as a potential cause, but has clear hypertrophy. And I'll show you a little bit of data from the North American Cardiomyopathy Registry. There are some data that are available from that now. And this accounts for about 40% of childhood cardiomyopathy. These are some of the causes. You probably can't even read it, but you'll be able to read it in the slides that you can get. They're familial, of course, that are sarcomeric proteins or mitochondrial diseases, syndromic things like Noonan's or Beckwith-Wiedemann, neuromuscular diseases, particularly Friedreich's ataxia, and then a lot of metabolic things, glycogen storage diseases, lipodystrophies, a number of other mitochondrial diseases that can present this way. And one of the important things is to distinguish between physiological hypertrophy and hypertrophy that's pathological. And some of the criteria that can be useful for this is that people with physiological hypertrophy, usually athletes or very active people, have normal or enlarged left ventricular cavities, and if you exercise them, their response is to have at least normal oxygen consumption, whereas people with pathological hypertrophy tend to have smaller LV cavities, not quite normal or a little bit small, abnormal diastolic function, and then family histories or evidence of delayed enhancement by gadolinium, as Dr. Hasbani has shown you in the past. Here's an example of hypertrophic cardiomyopathy. Here's the right ventricle. You can see it's a little bit hypertrophied, but not much. There's some fairly thick muscle bundles here in the right side, but it's not terribly hypertrophied. If we measure it, it's a wall thickness of about 7, which is a little bit increased for the right ventricle. But here's the left ventricle. It's about 30 millimeters. So there's no doubt that this is hypertrophy. We don't have to worry about distinguishing this from an athlete heart. So this is classic hypertrophic cardiomyopathy. The anterior wall here, it's pretty concentric. If we measure the septal thickness here, we'll see that it's almost 30 millimeters. There's the probe just coming through the septum on the right side. And then if we measure that, we can see that this is about the same. It's about 30 millimeters as well. So this is a fairly concentric hypertrophic heart. There's lesions on the anterior mitral leaflet here that we often see, contact lesions, also lesions here on the interventricular septum from systolic anterior motion of the mitral valve that can produce a little fibrosis in these areas. Histologically, this is a normal myocardium up here with very nice parallel myofibers. Here you see the myofiber disarray, fibers running in all directions here. And this seems to be part of the problem, is that instead of everything pulling together, fibers are pulling at cross purposes. And so the force distribution is very abnormal in this kind of myocardium. There's also a lot of fibrosis in these hearts. Here you can see on a trichrome stain, the greenish stain here is collagen fibrosis in all around the myocytes, much more than what you would expect to see. And you see areas of replacement necrosis here, little areas like this that are sort of semicircular clumps of fibrosis where there's been episodes of ischemia, tissue death, and replacement. And outcome in this really depends on the cause. Inborn errors of metabolism do much worse, as you might expect, whereas familial types of hypertrophic cardiomyopathy or neuromuscular diseases do better. And then there's malformation syndromes and other things in between. Dilated cardiomyopathy means an enlarged left ventricular chamber and reduced systolic performance without an inappropriate increase in wall thickness. And from the cardiomyopathy registry, this makes up about half of childhood cardiomyopathy, about 1.2 per 100,000. And interestingly, if we look here, we see a lot of the same genes. They're sarcomeric proteins, they're structural proteins. For a while, it looked like hypertrophic cardiomyopathy was primarily sarcomeric proteins or contractile proteins, and dilated cardiomyopathy was mostly structural proteins, but that's clearly not true. There's a tremendous overlap, and so there isn't any clear rhyme or reason to that. Here's an example of a dilated cardiomyopathy. Here you can see this is a very large ventricle. Look where the papillary muscles are here, way up toward the base of the heart. All of this is dilation, and you can see all the big muscle bundles. And notice the sort of pearly, slick appearance of the endocardium. There's a little endocardial fibrosis. It's not very much, but a lot of these hearts develop some subendocardial fibrosis, probably from increased wall stress and ischemia. The right ventricle, on the other hand, looks pretty normal. It's maybe has slight increase in wall thickness here, possibly because this patient had a little pulmonary hypertension. But otherwise, the right side typically looks relatively normal in these. Most of these involve primarily the left ventricle, although I suspect the right ventricle is somewhat involved. There's not a lot to see on histology. Sometimes there's edema, as you can see the clear spaces around here, increased size of lymphatic vessels, but really not so much else. Myocarditis is one of the causes of this, as we know, and this just lists for you some of the known causes of myocarditis. An interesting thing is now we're starting to see Coxsackie B some years ago. Coxsackie viruses, enteroviruses seem to be the primary cause. Now we're starting to see parvovirus as the most frequent organism that we find in myocarditis. So seems like there's been some shift in the viral cause of myocarditis. This is an example. Actually, let's just skip that and go right on to the. It looks just like a dilated cardiomyopathy. The characteristic features of myocarditis, of course, are inflammatory cell infiltrates. Here you see all these blue nuclei which shouldn't be there. These are lymphocytes and other inflammatory cells that grow in. Here you can see some myocardium over here, but look at this area. This is replacement necrosis. This is where the tissue has died from the effects of the inflammatory cells and has been replaced with collagen with just fibrous tissue. You see how different it looks from the myocardium. It's sort of smudgy areas over here like this, and you'll see these all through the myocardium in patients with significant myocarditis, as well as all these little round blue cells, which are lymphocytes and polymorphonuclear leukocytes. The outcome of dilated cardiomyopathy, and again, this is Jeff Tobin. This is some early data from the cardiomyopathy registry. The outcome is much better for patients who have myocarditis or familial idiopathic dilated, familial dilated cardiomyopathy, not the idiopathic kind. And patients who have neuromuscular diseases with dilated cardiomyopathy do quite a bit worse. So the risk factors that they found was age greater than 6 at presentation, not myocarditis, some other cause, congestive heart failure at presentation, and certainly the lower the ejection fraction or the worse the function at presentation, the worse the outcome. Restrictive cardiomyopathy usually has normal or decreased volume of both ventricles, normal wall thickness, but dilated atria, biatrial enlargement, and abnormal filling pattern based on Doppler or other measures of diastolic function. And again, there are sarcomeric proteins, non-sarcomeric proteins, acquired types. Myocarditis can cause this, sarcoidosis, diabetic heart disease can do this kind of thing. Some drugs, things like adriamycin, in fact, can cause a restrictive cardiomyopathy. So there are a lot of causes, a lot of overlap with the other kinds of cardiomyopathy that we've seen. Endomyocardial fibrosis or endocardial fibroelastosis worldwide is one of the causes of this. And here you see a patient with primary endocardial fibrosis. There is some thickening of this ventricle, but look at the pearly, slick appearance of the endocardium, also here on the papillary muscles. Here's the right ventricle. This is normal appearing endocardium over here, and look at the difference here in the left ventricle. There's thickening of the endocardium. This is like a peel on the inside of fibrous tissue that causes restriction of the ventricle. And you can see the difference here compared to the right ventricle. This is secondary endocardial fibrosis. This is in a patient with outflow tract obstruction. You can see they've tried to peel away part of this down here, exposing the underlying myocardium, but you get a sense of how thick this endocardium can be in secondary forms of endocardial fibrosis. And here's the thick fibrous peel on the inside of the ventricle. You can see myocardium under here, and look how thick the endocardium is here, mostly just collagen and fibrous tissue. Right ventricular cardiomyopathy, or arrhythmogenic right ventricular dysplasia or cardiomyopathy, is generally a heritable cardiomyopathy. At least 50–60% of the time you can find a gene that causes it. It results in arrhythmias, heart failure, and sudden death. And there are several phases of this. There's an early phase where there may not be much in the way of structural change, but these patients in this conceal phase still are at risk for arrhythmias and sudden death. And then an overt electrical phase where there are symptomatic arrhythmias and beginning to see the morphological changes in the right ventricle, the fibrofatty replacement of the right ventricular myocardium. And then later this can result in really a dilated cardiomyopathy or a restrictive cardiomyopathy appearance. And this is, we now know, is a desmosomal disease. Desmosomes are areas of cell-cell contact for force transmission and also for communication, cell-cell communication. And these structures do other things within the cell. Particularly, for example, desmoplakin here is involved in transcription and apoptosis regulation and in Wnt beta-catenin signaling. And without this nuclear portion of the activity of desmosomes, we can get replacement of fibrosis and replacement with fat. Also, these desmosomes interact with the sarcoplasmic reticulum and are important for calcium regulation and calcium hemostasis. So the mechanisms seem to be poor force transmission with cell disruption, fibrofatty replacement, and what's come out lately is, again, as desmoplakin, as I said, impairs Wnt beta-catenin signaling, and this can lead to a switch from a myocyte progenitor phenotype to an adipocyte, and this may be part of the reason that we get fat here so much and see that as such a prominent part of this phenotype. And the other thing that's come out, I didn't put it on the slide, but that's come out recently, is that this seems to be much more prominent in cells that come from second heart field, which we know are cells that generate the right ventricle. And so that may be an explanation for why the right ventricle is disproportionately affected in these patients. And here's an example. You can see the fat streaking here through the myocardium in this patient who underwent transplantation for his disease. And this is right ventricle. This is actually septal band up here. This is right ventricular free wall where it's more prominent. But look, over here, even in his left ventricle, and we now know that this is the case, that the left ventricle is often involved in this. Here you see the fibrofatty replacement through the wall of the left ventricle. It was a lot more patchy in his left ventricle, as it often is, and much more diffuse in the right, but it certainly involves both. And this is the histology of these. You see the fat here. It drops out in typical histology sections. This is all fibrous tissue, and there's just a little bit of myocardium in this section up here. All the rest of this is fibrofatty replacement transmurally in the right ventricle in this patient. And finally, LV non-compaction, a newly recognized abnormality, spongy myocardium. And we've heard about this already. It can be isolated or can occur with other congenital heart defects. And the natural history of this really is pretty much unresolved. It seems to be pretty variable, and it's a bit hard to predict. It can include systolic dysfunction, heart failure, but there are some people who are discovered as adults who have what looks like a spongy myocardium but don't really have much in the way of symptoms. There are a few studies that have begun to look at the genetics of this, and not surprisingly, we see some of the same sarcomeric proteins involved here that we see in hypertrophic and dilated cardiomyopathy, myosin heavy chain, cardiac actin, troponins. All of these seem to be involved in this as well as the other. Here's what it looks like. You can see in this section. Here's the compacted layer. This is the non-compacted layer, 2 to 3 times the thickness of the compacted layer, which is the sort of standard diagnostic criteria. Here you see another example of this, with heavier trabeculations here in the ventricle and a very thin compacted layer out here. So that's a sort of a whirlwind tour of cardiomyopathy. Dr. Silverman.
So, Steve, while you talk about right ventricular arrhythmia dysplasia, you want to also tie in this with the Yule's anomaly as
They're very different, I think. Yule's anomaly really is presents earlier. It's probably more congenital. Right ventricular dysplasia presents later. Yule's anomaly usually presents primarily with heart failure rather than with arrhythmias. Arrhythmias are not very common in Yule's anomaly. So I think they're really different diseases, but they probably are somewhat related. There's dropout of myocytes in the right ventricle, but it's more fibrous replacement in Yule's.
That's true. I was in South Africa recently, and they've discovered a gene amongst the indigenous population where some of the patients express as Yule's anomaly, and other family members present as right ventricular dysplasia.
It's not surprising that they would be related. It's just that phenotypically and clinically they look very different. But yeah, it's not surprising that you might find a common gene, just like you find, the sarcomeric genes are involved in all of these things, except for ARVD, which is really primarily the desmosomal genes, which can also present with hyperkeratosis in the skin, abnormal hair, because the desmosome is also very much involved in skin. Naxos disease, which from the island of Naxos in Greece, which was the prototype of this. These people have hyperkeratosis and kinky hair and all the rest of that. Yeah?
And there's one brief question. You talked about athlete's art. It's always a problem to distinguish. So what I just have in mind, I have a 14-year-old girl. She's an athlete. Her father has hypertrophic cardiomyopathy. She's like in the...
That's a big strike against her right there.
Yes, and her ventricle is like 12 millimeters right now. 12 to...
I'd be very suspicious.
So am I, but they won't stop. So the recommendation concerning this really competitive sports.
How's her father doing?
He is going for a marathon and so on. He is like a 20 to 25 millimeters.
How old is he?
He's like a 40 something.
Done pretty well.
Yes. So, but I have the problem.
No, I would agree. I would be very worried about that.
They won't.
Well.
I just.
There's nothing you can do but advise them, and I think that's right. It would be.
They went to a professor, to another one, and he told them it is not hypertrophic and said 12 millimeters. That's adaptation. So
and it could be. He might be right. He might be right, but with a family history, boy, I just think you can't just not assume that this is hypertrophic cardiomyopathy. Yes. It might, yeah. If you could find the father's, if you could figure out what the mutation is in the father and test the girls. There's so many mutations. There's so many mutations. I mean, there are hundreds of mutations now known. So you really have to test the father if he really has it and figure out what he has.
But according to Marin, you don't have, if you test, you don't have any prognostic.
At this point, there isn't very good correlation between a known gene, and there are a few genes that are known to be particularly bad actors. But it's right, there isn't a very good correlation. But if you showed that she had the same mutation that her father has,
that's right.
you know, then you've done all you can do, and it's up to them to decide how they want to deal with it. I mean, they
Do
can.
you have a maximum value of wall thickness 15 millimeters also? No.
No,
There's
I don't.
no such thing.
No, I don't think there is any such thing. It's not
Okay.
that clear a cutoff.
Okay.
It just doesn't work that way. I mean, I think the other thing you can do for people like this that you're really worried about, if they're really trained athletes, is to have them detrained for a few months and see if it goes away. I mean, a lot of people won't do that, but it's one approach to it that people have used a lot.
Yeah, thank you.
The other thing is you have to also look specifically at what kind of stress the athletics put on the heart.
Yeah, that's right.
So, for
I mean, if
example,
you're doing weightlifting or
as a
something,
weightlifter, it can become very difficult
Yeah,
because
yeah.
they can generate, big athlete, Olympic athletes can generate 400 millimeters of mercury blood pressure
They can.
during a press. So they have these small volume hearts with thick ventricles. Swimmers, basketball players and runners tend to have a more dilated ventricle with mild thickening of the ventricle. So you really have to look at what kind of exercise your patient is doing to further help find that out.
That's exactly right. Running has a very different effect
Yes,
than.
he's running.
Yeah.
Okay.
Other questions? Yes.
Yes, and concerning cardiomyopathies,
Why don't you
what
begin?
makes us sure that the pattern we find even in biopsy, endomyocardial biopsy, is causing the sickness, and it's not just there?
I'm sorry, say that again.
That, for example, the effect of the myocarditis, and it's not just
Well, I mean, there have been enough studies in other kinds of diseases looking for viral genome, and you don't really find it in the heart very often. So you're right. I mean, it could be just a byproduct of something else. But I think based on what you know about the findings of biopsy, the findings at explant and that sort of thing, that's not very likely. We know also that it can cause disease in utero, there's just been a shift
That's
in the
way over.
in dilated cardiomyopathy without myocarditis.
That's it at the beginning. Well, my task today is to discuss with you the problem of cardiomyopathy in the fetus and newborn. Now, as I was sitting there listening to Dr. Sanders, if Dr. Silverman will permit me, I'd like to devote a few extra minutes to begin with to talk a little bit about the myocardium in the fetus versus postnatally, because we tend not to recognize that there is a striking difference between the myocardium before birth and after birth. Now, there's a lot of studies to show, first of all, that the myocytes before birth are very different to the myocytes after birth. In the fetus, the myocytes are much smaller, and for the same muscle mass, you will find many more myocytes in the fetus than in the postnatally in the adults. In the studies we did in sheep, we found that the myocyte diameter in the fetus was 5 microns versus in the adult about 15 to 20 microns. Now, if you think of that in terms of cross-sectional area, it's a difference of about 150-fold. So it's an enormous difference in size. In addition, the myocytes are longer in the adult than in the fetus. Now, what's more important, though, also, is that when there is an increase in myocyte mass, so any increase in the amount of myocardium, in the fetus, with normal growth, all increase in myocardial mass is by hyperplasia. In other words, it's all an increase in cell numbers. And if you look at the myocytes in the fetus, each myocyte has only one nucleus. It's uninuclear. When you look at the postnatal situation, when there's an increase in muscle mass, it's almost not at all by hyperplasia. There's almost no increase in cell numbers. It's exclusively by increase in myocyte size. Now, I stress this because I think it's very important to recognize that what happens in the fetus may have no relationship to what happens postnatally. Now, we know, for example, from studies we did in lambs too, that when we induce a stress on the myocardium, which increases muscle mass, that you get exclusively hyperplasia, so that when we produce pulmonary stenosis or aortic stenosis in a fetus, and we look at the myocardium, the myocardial thickness of the right or left ventricle increases strikingly, and the weight of the myocardium increases in the respective ventricle. But you look at it, and it's only increase in cell numbers, no increase in cell size. Whereas postnatally, if you do this, there's almost no increase in cell numbers, and it's predominantly increase in cell size. And this is important because we also know that there's a big difference in function of the myocardium in the fetus and newborn. Many years ago, Dr. Friedman showed that when he looked at a particular way, a segment of muscle taken from a fetus, and looked at a similar segment taken from an adult heart, these are with the same weight of muscle, that the force generated by the fetal muscle was far less than that generated by the adult muscle. So there are these big differences, and we really need to recognize this when we think about what happens with cardiomyopathy. Now, it's also interesting, as I've mentioned, this is the usual description of the classification of cardiomyopathy. But you should recognize that when you look at the incidence of cardiomyopathy in the fetus and newborn, the causes are vastly different to what you see postnatally. You know, we think about genetic cardiomyopathy, we think about infectious cardiomyopathy. These occur in the fetus, but they're relatively rare compared to the other causes. So what I'm going to concentrate on today is the common causes of cardiomyopathy in the fetus and newborn. I'm not going to discuss much about the other causes, the infectious causes and that, because they are similar to what you'll hear discussed by the other speakers today. So, if we consider dilated cardiomyopathy, the most important causes are, first of all, arrhythmia. Now, you say, well, arrhythmia is not a cardiomyopathy, but studies have been done in sheep fetuses in which you can induce eye drops by persistent stimulation of the atrium. So if you produce an atrial tachycardia for as long as 3 days, these fetuses develop eye drops, so they go into cardiac failure. Now, the interesting thing is that if you look at the human, that excuse me, that tachycardia, atrial tachycardia, is sometimes recognized clinically, but usually the first time that one knows that there's a tachycardia is because the fetus has gone into failure and the fetus presents with high drops or some other problem, some distress, and then you examine the fetus and you find that there's a tachycardia. And the thing to recognize is that this tachycardia has to be there for some time before it produces these problems. what is interesting is when we studied tachycardia in fetal lambs, we found that when you stimulate the atrium, there's a tremendous change in the intraatrial pressure in the left and right atria. So that if you stimulate the right atrium, you will find a marked increase in the A wave in the right atrium, and you will see that cardiac output is maintained reasonably well. But if you produce a stimulation of the left atrium, cardiac output falls because you produce a dominant wave pattern in the left atrium and interfere with flow across the foramen from the right to the left, and therefore interfere with left ventricular output. Now, the second common cause of hydrops in fetuses is anemia. Now, the most important causes of anemia, it's usually either immunization problem, and particularly in the past, Rh incompatibilities, but other incompatibilities can also produce anemia. Now, we know from studies in animals that moderate anemia induces an increase in output of both ventricles. And the reason for that is to try to maintain oxygen delivery to the tissues and maintain the delivery from the placenta. If you drop hemoglobin concentration, the amount of oxygen delivered in each volume of blood is reduced. So in order to maintain oxygen delivery, you have to increase not only cardiac output, but very importantly, umbilical blood flow. Now, it's interesting that it doesn't take long with moderate anemia. We've done these studies in sheep fetuses. With moderate anemia, you get quite rapidly enlargement of the heart. And obviously, you're increasing volume output by the heart, so the heart enlarges, and both ventricles are involved. Now, in order to provide this increase in output, you have to increase coronary blood flow. And this becomes a problem because in the fetus, coronary blood flow can be increased very markedly by up to 4 or 5-fold in order to provide oxygen supply. But you get to the point where if anemia is severe, that it cannot provide, even with this increase in coronary blood flow, it cannot provide adequate oxygen to the myocardium and failure occurs. Now, it's also interesting that, you say, well, this isn't cardiomyopathy, just because the ventricles are working harder. But you do get histological changes in the ventricles. And there's been an interest recently in studying what happens with anemia. And as you see here, in addition to the cardiomegaly, there's an increase in myocardial thickness of both ventricles. And in fetal sheep with chronic anemia, Bernard has shown that there's both impaired systolic and diastolic function. Now, furthermore, in a very interesting study by Jonker, he showed that myocyte size increased slightly, but there was a marked increase in myocyte number. Now, we don't know what happens, and this is why I introduced this discussion by mentioning what happens in the fetus with stress, that you get an increase in myocyte numbers. We don't know what happens with these myocytes. So that, for example, if you have a fetus that develops, that has pulmonary stenosis, and you have marked increase in myocyte numbers, we don't know what happens after birth. Are these myocytes capable of performing the same work as the adult myocyte, the normal adult's myocyte, or are they not able to do so? Or, in fact, are they able to undergo the same degree of hypertrophy that's necessary postnatally to increase muscle mass as if they would, instead of being normal myocytes? So we don't know this, and I think this could be terribly important in terms of what the postnatal behavior is of these hearts. Now, the next important cause of cardiomyopathy. Oh, incidentally, I should mention that both with tachycardia and with anemia, once you've corrected the condition, the heart does not immediately return to normal size. And particularly with anemia, the heart stays enlarged for many weeks after you have corrected the anemia. So that this is not an immediate recovery once you correct the cause. And this raises the important question whether these fetal insults to the heart could result in permanent damage to the myocardium. Now, the volume loading on the heart, there are two important causes that are AV aneurysm type of malformations. The first is great vein of Galen aneurysm. Now, it's an arteriovenous shunt, and if it's large, it can produce hydrops in the fetus, but it's much more likely that failure will occur after birth than before birth. But we have seen fetuses with AV fistula in the brain who have developed hydrops in utero. Now, we don't know much about the pattern of blood flow, but if you think about this, what is happening is that there's a large extra volume returning to the heart through the superior vena cava, coming from the brain. And this is interesting because if the superior vena cava flow pattern follows the normal pattern that you see in the fetus, all this blood should go through the tricuspid valve into the right ventricle. Now, it's possible that this large flow could interfere with the drainage of the inferior vena cava blood with a preferential flow of ductus venosus and left hepatic vein flow through the foramen, but we don't know whether this is interfered with or not. But it is interesting that in these babies who have great vein of Galen aneurysm, there is quite a high incidence of sinus venosus atrial septal defect. And why this occurs we don't know, but it's suggested that if this shunt occurs early, it interferes with the development of the region of the sinus venosus and maintains the persistence of an opening in this region. But it is interesting that there is this association. The other thing that's important, of course, is that there is a high incidence of coarctation of the aorta in this lesion. Now, this is easier to explain, at least for me, because it fits in with what we've been talking about the last few days of flow patterns. Now, if you think about what happens with a great vein of Galen aneurysm, the blood that's ejected into the ascending aorta from the left ventricle predominantly is going to go into the shunt, so that the amount going across the aortic isthmus is going to be reduced considerably. The blood returning to the heart returns to the right atrium and then goes through the tricuspid valve into the right ventricle, It's ejected into the pulmonary artery and then goes through the ductus arteriosus to the descending aorta. So you have a marked increase then of ductus arteriosus flow. And based on the Hutchin principle that we talked about, this is the exact setup to produce coarctation. And in fact, there is a high incidence of coarctation of the aorta in these babies. Now, the other volume load, and I'm not going to spend much time on it, is particularly sacrococcygeal teratoma, and with large shunts through the sacrococcygeal teratomas, you can get high drops and typical cardiac failure. Now, I've just mentioned the other causes of fetal cardiomyopathy, infection. Parvovirus has been blamed quite frequently these days. Before the recent concentration on parvovirus infection, the commonest infection which used to affect the fetus was Coxsackie, particularly B6, but it caused a general viremia, and it was not a specific cardiomyopathy that was involved. And then toxins, we know that anti-neoplastic drugs and antiviral drugs, but the genetic cardiomyopathies, as I mentioned, are rare in the fetus. Now, one of the important things, one of the commonest causes, in fact, of cardiomyopathy in the fetus, and now we're talking about hypertrophic cardiomyopathy, where the heart is considerably enlarged and the ventricles thicken, is twin-to-twin transfusion. Now, this is a condition in which there is in which there are monochorionic twins, and where there is a connection from the artery of the umbilical vessels of one fetus, or the umbilical arteries of one fetus, to the umbilical veins of the other fetus. Now, you can imagine that what happens under the circumstance is that with the higher pressure on one side and the lower pressure on the other side, there's a persistent passage of blood from the donor fetus to the recipient fetus. Now, interestingly, associated with this, what you find is that the donor fetus is small and oligohydramnic. The recipient fetus is large and polyhydramnic. But what the main manifestation clinically in these fetuses is that the recipient fetus has a big heart with increased wall thickness. It's hypertrophic cardiomyopathy. Interestingly also, there have been some studies done on this by ultrasound, and what you see, as you see from this study mentioned there, is decreased shortening fraction, shortening ventricular filling time, suggesting that there's both systolic and diastolic dysfunction. And interestingly, the right ventricle is affected more than the left ventricle. That's interesting to me. I would have expected the opposite, because since this blood is coming back into the umbilical vein, I would have expected it would be directed more towards the left ventricle through the foramen. But it's interesting that the right ventricle is affected more, and I can't explain why that occurs. It's probably just the overall effect of the increased volume, because the evidence is that these fetuses, the recipient fetus, is hypertensive. Now, you recognize, of course, that when you look at these, if you see, I didn't bring a picture of these, but when you look at these two fetuses side by side, it's just dramatic. You see the recipient fetus, big, bloated, and bright red. And you see the donor fetus, a little, scrimpy little thing with pallor. So it's because it's continually giving blood to things. So the concept, one thing that's important is these disturbances become progressive with advancing gestation, so that the myocardial problem becomes progressively worse in the recipient fetus. Now, it's been suggested that all this is just due to a volume, that the high volume going into the recipient fetus is responsible for hypertension, increased loading on the circulation, and that this causes the myocardial problem. However, it seems that this is not the only factor involved. It's been suggested that the fetus, that the donor fetus releases renin in response to the hypovolemia, that this then crosses into the recipient fetus, in the liver gets converted to angiotensin II, and that the angiotensin II results in peripheral vasoconstriction, hypertension, and causes the problem. What's also very important, incidentally, we know this is correct because we have shown in sheep fetuses, in fetal lambs, that angiotensin II liberation does not occur with hypoxia, but if you reduce blood volume in the fetus, there's a potent release of renin and angiotensin II. So that this would fit perfectly, that the donor fetus is now stimulated to produce renin, which goes in and is converted to angiotensin II and produces this loading of the circulation in the recipient fetus. Now, it's also interesting that this may not just be a loading problem, but it may be a direct problem of the effect of a direct effect of angiotensin II on the myocardium. Because we know that in the adult heart, hypertrophy is very much stimulated by angiotensin II release. This is the reason why A2 inhibitors are used in adults often to try to prevent some of the hypertrophy that occurs as a result of an angiotensin II effect on the myocardium. In addition, angiotensin II, in addition to causing hypertrophy, increases collagen formation, so that these hearts have more fibrosis as well as increased muscle mass. And the question then is whether this effect on the heart may be a long-lasting effect, and that even, as you know, these twin-to-twin transfusion syndromes are now treated by going ahead and closing the communication between the two fetuses and preventing this release. Usually the donor fetus does not survive, but the recipient fetus does. But the point is that it doesn't necessarily mean that the fetus is going to be perfectly okay subsequently. They seem to be all right, but we don't have good studies or long-term studies to know what happens with them. The other interesting thing that we observe in these twin-to-twin transfusion babies is that there's a high incidence of pulmonary stenosis. And that's an interesting thing. We don't know why this occurs. It's been suggested that what happens is that because of the peripheral vasoconstriction, they get a rise in aortic pressure, and through the ductus, this causes backward pressure on the pulmonary artery, like we talked about in Epstein's malformation, and then this closes the pulmonary valve. But this doesn't seem to be the case, because in these fetuses with twin transfusion who have pulmonary stenosis, there's usually a very thickened infundibulum in the right outflow tract. And there is also increased endocardial formation in the ventricle, the right ventricle. And we did some studies many years ago in which we infused 5-hydroxytryptamine into newborn puppies, and we found that chronic infusion of 5-hydroxytryptamine resulted in marked endocardial proliferation in the heart, and many of these puppies developed both tricuspid and pulmonary stenosis. So I think it may be that in the same way that there is the stimulation for the release of renin and with angiotensin II result, that there may be some other humoral factor which is responsible for this change, but I don't know. Now, what I've stressed then is that that is really an important cause because, again, it's something that can be treated if you recognize it. Maternal diabetes is well known to cause fetal cardiac growth and increased muscle mass. I'm not going to spend much time on it because I'm already late, but we know that fetuses with maternal diabetes develop increased heart size and increased muscle mass. It's not necessarily only in the mother where there's no control of the diabetes. Usually it's in mothers in which there's no control, but it can occur even when the mother is well controlled. And it's almost certainly the result of insulin production in the fetus. We know from studies we did on fetal lambs that when we give insulin to the fetus directly, that the heart mass increases. We see, particularly what you see in this condition is an increase in septal mass. And why that occurs, I don't know, but it's predominantly septal hypertrophy that you see, ventricular septal hypertrophy. I can't explain why that seems to select predominantly that region of the heart, but it is a fact. And then Noonan syndrome, we know that hypertrophic cardiomyopathy has been identified in the fetus. It usually is involved predominantly the left ventricle, and postnatally it can produce left ventricular outflow obstruction, but it's never been observed in the fetus, so that I think it's just a matter that it's a progressive condition which presents postnatally and doesn't present in the fetus. Okay, so let's now go on to dilated cardiomyopathy in the neonate. So we're going now from the fetus to the newborn. And I mentioned infection, and again I just stress that the commonest infection that used to cause myocarditis with cardiac failure in the newborn infant was Coxsackie B6. It used to occur in epidemics in nurseries. We don't see it much anymore, but it's really not a specific cardiomyopathy. It's just a general severe viremia with cerebral involvement, cardiac involvement. So the heart is just part of the general viremia. And then we come to the issue of great vein of Galen aneurysm, which I mentioned occasionally causes a problem in the fetus, but by far more common, the problem occurs after birth. Now, why should the problem occur after birth so commonly? Because it's very common with large great vein of Galen aneurysms to see a baby who develops cardiac failure within a few days after birth. And why is this? And I think the reason is the pattern of blood flow. Now, in the fetus, the blood returning to the right ventricle largely goes through the ductus arteriosus down to the descending aorta, doesn't return to the left ventricle. Postnatally, when pulmonary vascular, and incidentally, in the fetus, pulmonary vascular resistance is high, so there's not a lot of blood going through the pulmonary circulation and back to the left side of the heart. Postnatally, though, when pulmonary vascular resistance falls, the volume of blood going through the pulmonary circulation is markedly increased, so that the pattern of blood flow of this extra blood coming back to the right atrium, right ventricle, is to go into the lungs, not across the ductus arteriosus. That blood goes back to the left side and now presents an extra volume load on the ventricle. So that now you get an enormous increase in volume load on the left ventricle, and that's what really results in the failure. It's interesting, you remember I mentioned that there were certain conditions in which the oxygen saturation in the lower body could be higher than that in the upper body, and this is one of them, because you can realize that if the ductus arteriosus is still open, the blood coming from the great vein of Galen through the superior vena cava has a high oxygen saturation. It's deflected excuse me, into the tricuspid valve from the superior vena cava into the right ventricle, and if the ductus is open, that blood's going to go down to the lower body. So that it's one of the conditions where you see a higher oxygen saturation in the lower body sometimes. Anyhow, the other important thing that I want to mention again is to have you realize that we assume that once we correct the initial lesion, that this heart is going to be fine. But we really don't know that. And particularly here, before birth, there's a large extra volume load on the heart. The heart increases in mass. It's almost entirely by hyperplasia, and we don't know what happens to these hearts after birth. So, now, the last things I want to talk about are hypertrophic cardiomyopathy in the neonate. And the first is, again, in the infant of diabetic mothers. You sometimes find this, but it usually doesn't cause much of a problem. As I mentioned here, that familial hypertrophic cardiomyopathy of the genetic variety is very unusual in the newborn period. You don't see it in the newborn. You usually manifest later. One of the important ones is Pompe disease, which is an alpha-1 4-glucosidase deficiency, and this produces massive glycogen accumulation in the heart. It usually presents with cardiac failure within a couple of weeks after birth, but sometimes may not present for 4 to 6 months. And there's marked hypertrophy of the heart. There are this involves, of course, other muscles, so the skeletal muscles are often increased in size. And one of the clinical features that's characteristic is a big tongue. And the electrocardiogram shows characteristically a short PR interval with very, very large voltages. But the other interesting hypertrophic cardiomyopathy is corticosteroid therapy in the newborn. At one time, it was very popular to try to improve lung function in premature infants who had bronchopulmonary dysplasia associated with hilar membrane disease, to give them corticosteroid. And it was very common in these babies that they developed cardiac hypertrophy, particularly again of the ventricular septum. And it was so prominent that many of these babies developed gradients across their left ventricular outflow tracts. And we saw some infants in which the gradients were as much as 60, 80 millimeters of mercury. As soon as the steroid is stopped, the heart begins to decrease, the gradient disappears, and the hypertrophy disappears. But again, we do not know what the permanent result of that is. We do know that corticosteroid is an important factor in causing the maturation of the myocyte. Remember, I told you that the myocyte in the fetus grows by hyperplasia. The myocyte postnatally grows by the muscle mass grows by hypertrophy. We have shown in lambs, fetal lambs, that when we give corticosteroid to the fetus, that it changes the way in which the muscle grows, and we see that hypertrophy occurs rather than hyperplasia. And again, what the impact of this is on ultimate cardiac growth, we don't know. Thank you.
So many questions that are raised from that. Is there anybody who would like to ask Dr. Rudolph a question? We have seen fetuses that have presented to us with a genetic history of cardiomyopathy that look totally normal. And then at birth, within a few days, they present with profound failure, endocardiofibrosis, and dilated.
Yeah, I know that that's true, Norman, and it's a very interesting thing. And it raises the question in my mind as to whether this is because of the change in the growth pattern of the heart. Incidentally, I mentioned to you that the fetal myocardium, these myocytes have one cell. As you probably know, adult myocytes have more than one nucleus. I mean, they have one nucleus. Adult myocytes are polynucleate. And it's obvious that there's a big difference in the growth pattern. And it may be that in the hereditary cardiomyopathies, that it only manifests after birth because that's when the growth of the myocyte is different. But I don't know. Interesting.
Thank you. Anybody else? Thank you. I'm going to go through this rather quickly so we can keep on time. We're going to talk about cardiomyopathies from the ultrasound point of view, and we'll discuss the various types that were outlined by Dr. Sanders. And I will confine my remarks exclusively, or almost exclusively, to the postnatal situation. So we have very limited abilities in cross-sectional echo. Dr. Shirali is going to discuss with us our weaknesses in terms of measurement and assessment of cardiac performance by ultrasound. But we have the usual indices, the usual suspects that you know about: fractional shortening system, ejection fraction, end-diastolic dimensions, wall thickness, and so on and so forth. And in the past, these have been done by M-mode echocardiography, and they do, when on the gross sections, produce real obvious indications of dysfunction. As you can see in this cross-sectional image below, there's very poor contraction of this left ventricle, which leads to very minimal change of dimensions. And also looking at the timing of aortic opening to closure, you can see real prolongation of the QRS complex as the ventricle squeezes to open the aortic valve, and then the aortic valve closes fairly rapidly. In the normal heart, this period is 1/3 to 2/3, and as you can see here, it's 1:1, which is another profound abnormality. Now, we can also look at valve motion as a reflection of ventricular pressure. And here on this echocardiogram, you can see what is called a B-notch. In the old days, for those of you that still do M-mode, this is C, D, E, F, H, A, B, and C again. So this B-notch relates to an elevation of end-diastolic pressure. When the valve tends to close, if the end-diastolic pressure is high, the valve doesn't close and it forms a little notch here. And I have a cartoon that shows clear evidence of another B notch over here and over here. And you can see when atrial pressure is elevated that instead of the mitral valve closing rapidly, it closes with this kind of a notch. And although this is not a fashionable index of ventricular performance, it is based on good hemodynamics. When you see a B notch, the left ventricular end-diastolic pressure is usually over 22 millimeters of mercury. And I still find it one of the most useful indices in cardiomyopathy. Now, when the left ventricle dilates, the mitral valve moves away from the septum, and this on M mode causes what is called E-point separation. This is the distance between the septum and the peak E excursion. And the more dilated the ventricle, the larger this diameter becomes. And this was an index developed at University of California, San Francisco in the adult area. And they normalized this for end-diastolic dimension so that you could calculate an angiographic ejection fraction based on the relationship of the E-point to the end-diastolic dimension. Now, more recently, we have the index which is called the TAY index, named after Chua Trey, who worked at the Mayo Clinic and spent a lot of his time looking at amyloidosis, a condition which infiltrates the myocardium and causes it to be very stiff and causes both systolic and diastolic dysfunction. And the TAY index uses isovolumic contraction time and isovolumic relaxation time, and uses ejection time as a surrogate of a baseline and establishes this interval. And if it's under 0.4, 0.5, depending upon the age, you've got good function, and if it isn't, if it's beyond that, it usually indicates that there's poor function. Now, when Doppler came along, historically, we were able to look at E and A and see changes in E and A, and in restrictive cardiomyopathy, the filling, because of the high end-diastolic pressure, gives a very high E wave with rapid descent, and as the pressure rises, the A wave becomes smaller and smaller, and so you get a almost absent A wave in this condition. And using this together with tissue Doppler, many people, including those from the Mayo Clinic where I got this slide, have established a relationship. If E over E prime is greater than 15, that there's usually a pulmonary capillary wedge pressure of over 20. Now, one of the things about all of these intervals is they seem to work a lot better in adults than they work in children. Another thing that has been used as an indication of function, is this so-called propagation velocity, which was developed by Jim Thomas at Stanford, at Cleveland Clinic. And he said that the flow into the ventricle, the rate of flow into the ventricle, which can be seen by this aliased velocity here, indicated the degree of filling. So the more rapid the filling, the less the end diastolic pressure. The higher the filling, the longer the interval became. We looked at this interval, Mark Friedberg and I, and found that, of course, what is causing the mitral valve to open, which is really passive, is the blood flow that enters into here. So if you could take this system here and remove the color Doppler, you got left with an M mode underneath here, and you could measure an propagation velocity of M mode just as easily. The only difference was that this was usually done from the parasternal area and did not get in a true direction. When we were able to do this from the apex, we were able to see that the interval was almost identical regardless of which method we used. So the Mayo Clinic group have put out this table as a summary of what happens in function, with good being on this side and bad being on that side, with a normal E and A, I beg your pardon, associated with mitral inflow Doppler signals. And then when there is a compromise, such as you get with hypertrophy of the ventricle in hypertrophic myopathy, there's a reversal. Then, because pressure changes, you get pseudo-normalization. And finally, with restriction, the A wave tends to disappear. So now when you look at, for example, pulmonary venous flow, there are equal systolic and diastolic waves with reversal. And as the pressure rises, the diastolic velocity tends to increase first, then increase, and the A wave increases progressively over this area. Here's the propagation velocity, and you can see as the ventricles become stiffer, the slope of the propagation velocity goes down. And lastly, we can look at tissue Doppler and see the velocity of motion of the tissue as a function of its contraction. And this changes as well, so that the E particularly goes down, and is that which the E prime, which gives rise to this abnormality and tends to indicate diastolic pressure increases. And you'll have this in your handout as well. Now, Dr. Friedberg and I have become intrigued by the periodicity between systole and diastole. And we looked at a number of cases where we were able to look at both the right and left side of the heart for what I call the systolic period and the diastolic period. So this is the contraction relaxation phenomenon, and there's a normal period. We know in the adult heart, for example, that systole occupies 1/3 of the cardiac cycle, and diastole occupies 2/3 of the cardiac cycle. Well, here's a patient with a restrictive cardiomyopathy, and indeed diastole is quite compromised, indicating diastolic abnormalities. And this picture you've seen before. Dr. Friedberg showed it yesterday in hyperplastic left heart. So this is from the right ventricle, and this is tricuspid regurgitation. And you can see that systolic and diastolic relationships are way different to what you expect to find them in the normal child. So we looked at this over a variety of normals, and we found that, not unsurprisingly, the systolic period, which we've known about for many, many years, from the days of measuring systolic time intervals, is really heart rate related. The faster the heart rate, the shorter the systolic period, and this is on a linear basis. And here is the linear equation that we established from this relationship. The look at diastole is completely different. diastolic relationship is more curvilinear, and this has been borne out over a variety of studies that have looked at diastolic function. And so you can see that if there's a curvilinear relationship with a rapid shortening early on and a slower response as heart rate increases, that if you look at the relationship between the two, you can get a curvilinear function of normality and decide what happens. Bearing that in mind, there is no study which has more than 1.6 of systole over diastole. So anytime you find an interval that's high, you can be sure you're dealing with an abnormality, even if the heart rate is fast. So now, just as far as the types of cardiomyopathy, here I've matched up with specimens, and you can see a lot of fibrosis in the ventricular wall here, especially in the septum, of a patient with the classical hypertrophic cardiomyopathy, just so that you know what they look like. And you can see not only is the acceleration of flow, that because of the increase in pressure, there's also, and abnormalities of the mitral valve, there's also mitral insufficiency noted. And here, just a parasternal long axis, look at that, comparing that to morphology. And we can understand here this so-called systolic anterior motion, first identified on M-mode echocardiography, and you can see here in systole, as this narrowed left ventricular outflow tract narrows progressively, the mitral valve gets sucked out into the left ventricular outflow tract, causing this little systolic anterior motion of the mitral valve. And when you look at this with Doppler color flow, that's the area where there's an increase in velocity across that area. Now, as a consequence of that, in hypertrophic myopathy, there's obstruction to left ventricular outflow tract, and when that happens, the aortic valve tends to drift into the closed position, and I have 3 or 4 of these pictures to show you over here, and this occurs clearly after 80 milliseconds after the onset of the QRS complex, which differentiates a dynamic left ventricular outflow tract obstruction from a fixed left ventricular outflow tract obstruction, which we'll show you later. You see this classical late systolic peaking, which reflects the signal of acceleration within the left ventricular outflow tract, as you see here. And obviously, these signals are sometimes obfuscated by the presence of mitral regurgitation, which is this early signal here that you see. Now, we can find this after post-transplantation, as Dr. Rudolph has said. This is a condition in which steroids are frequently given to aid in the prevention of rejection. So this is a secondary phenomenon that produces cardiac hypertrophy as well. As far as dilated cardiomyopathies are concerned, I've showed you that example. I'll just talk a little bit more about the Doppler findings here, showing in a very high E wave, a low A wave, and a decreased periodicity with the systolic diastolic ratio being quite abnormal, and the tissue Doppler findings, which I'm sure Mark will talk about a little later, showing depression both of systolic function here under 5 meters per second, 0.05 meters per second, and very low diastolic filling properties as well. I won't say anything about the IVA, Mark. I'm sure you'll talk about that too. And also, people measured the DPDT, and you can do that with calipers electronically and get an idea of the true peak DPDT, which is normally over 1,000 millimeters of mercury. Here it's only half the normal expected values. Also, when you look at diastolic, dilated cardiomyopathies, there's frequently rouleau formation that occurs in the ventricle as a consequence of the sluggish blood flow, much more prominent in the more modern systems, and has to be suppressed to create an image, but you can see how sluggishly the blood is moving in this condition. I've talked a little bit about restrictive cardiomyopathies with the elevated E and the low E prime that you see here, which is characteristic of elevated diastolic pressures. And again, this global index of function together with the TAE index that indicates prolonged systolic and diastolic components. Restrictive cardiomyopathies have what I call the classical ice cream cone appearance. They have small little ventricles with huge dilated atriums, and this is a very reliable sign, and you can see the dilated atriums and the atrioventricular valve regurgitation, as well as pulmonary hypertension. That is a phenomenon of this condition. And of course, we have to guard in the condition where the flow is so sluggish, or whether there's inflammation of the endocardium, of the presence of thrombi. And here is one patient with an apical and long axis view. And here is a short axis view in another patient showing a thrombus on the lateral wall of the left ventricle, and another patient with multiple apical thrombi associated with dilated cardiomyopathy. We also have this variety of cardiomyopathy, which is an endocardial fibroelastosis related largely to right ventricular findings. You can see here very small right ventricle, a huge pericardial effusion, and dilated atrium, and we can see this in a variety of views. And lastly, Dr. Sanders already alluded to the spongy myocardium. This is an example from David Sedmera's example of a 1 millimeter chick embryo showing beautiful fetal spongy myocardium, which becomes compacted over the period of time. And here are examples of cardiomyopathy with spongy myocardium. I think you can see that very nicely over here in the myocardium. And of course, we can look at it with cross-sectional echo as well as color flow, showing the blood flow coming in and out the crypts of the ventricle. And when you take this patient and you slice the cardiomyopathy, you can see, I think very nicely in this series of sections taken from the lateral wall of this left ventricle, the nature of the spongy versus the compact myocardium. And in systole, this is obviously post-mortem, but I think fairly characteristic here, you see that the spongy area is twice the thickness of the compact myocardium. And this is often associated with hydrops fetalis when it presents in utero and a variety of other conditions. And here is the M mode showing the compact and non-compact layer and how we make the measurements. And I'll just leave it at that. And thank you for your attention, and let the other speakers tell you more about cardiomyopathy.
Okay, good morning. I'm gonna be starting out talking about 2D pulse wave and other sort of Doppler modalities, and then I'm going to go on to talk about 3D echo. This is a study that just came out this month. Last month in the Journal of the American Society of Echo. It's actually one of the more important studies that I think has been done in the world of pediatric echo, looking at how we use measurements in echocardiography and echocardiographic measurements in children with dilated cardiomyopathy, how reproducible those measurements are, because it's important for us to know how reproducible they are. Otherwise, there's no real kind of point in making them. The Heart Network is a United States federally funded sort of a network It has 8 clinical sites, many of which are represented in the room. So you have Toronto, Boston, Columbia, New York, Children's Hospital of Philadelphia, Duke, and so on. There is a core laboratory that Dr. Kolan and his group run in the Children's Hospital in Boston. So everything that is performed by way of, echocardiograms are performed in all of these 8 sites, or more sites depending on what the study is. And then all the images are sent back, the DICOM studies are sent back to the core lab, and the measurements are made at the core lab. And then there's a data coordinating center and so on and so forth. Now, what this study was it was over a 2-year period, and it was a very complicated study design because we were just wanting to figure out the reproducibility of measurements. So there were some procedures that were done at the core lab, and then there were other procedures that were done at the local lab. So at the core lab, they had 2 different readers to look for inter-reader variability or reproducibility, all right? And they performed these measurements on 143 different measurements, all right? So these include M-mode, fractional shortening, pulse wave, tissue Doppler, isovolemic acceleration slope, MRDP-DT, Tay index, ejection fraction of the LV by 3 different 2D formulas, and so on and so forth. All things that we use routinely, not 3D stuff, just standard stuff. Okay. So 143 parameters, 3 beats each. So 429 measurements on each echo, and then one reader repeated all those measurements a month later to see how much they had varied in terms of their own. And then each of those things were measured by 2 people. Lot of work. And the types of variables were categorized like this. So there were areas, or things that were, an area is a traced area, right? So if you look at the parasternal short axis and you trace the endocardial area with that, with no calculation, that's according to this definition, that's an area. A calculation from 2 quantities is called C2. So for example, the fractional shortening is based on 2 quantities, end diastolic and end systolic diameters, and so on and so forth. Some more complicated things require 3 and even 4 quantities to calculate them. And the other explanations are fairly straightforward. This is actually one of the most remarkable slides that I've had the pleasure of showing. I'm going to just explain this to you. So this is looking at what the percentage error is. So the error is sort of the difference between the 2 measurements divided by the mean of the 2 measurements. So for example, if somebody measured, if you had one measurement of 4 centimeters and another measurement of 6 centimeters, then you have to believe something is the truth. So you take the middle as the truth, and then you look at the difference between those 2 things, which is a 2 divided by 5. So that's a 40% error. Okay, that's a lot. And what we're aiming for is we really want the error numbers to be below like 5%. Ideally. Maybe below 10% would be nice, but realistically, but below 5 in an ideal situation. So for these 2D M-mode pulse wave and tissue Doppler measurements, these are the error numbers that we got. This is looking at some really good centers. I mean, I know my center, MUSC at the time, not a good center, but the other centers are really very good, right? I mean, Boston, Philadelphia, all these are pretty good. Our center is pretty good too, actually, just by the way. And we're not measuring our error here. We're measuring the error made at the core lab, which is Boston, which is, great place. So this is inter-reader in Boston, intra-reader in Boston, okay, of images that are made by different people from different sites and sent to them. That include their own images as well. So if you make your measurement on 1 beat, your error between 2 people making a measurement is 11%. If you go to 2 beats, it's 10%. If you go to 3 beats, it's 9%. So you can decrease your error if you make measurements on multiple beats. And the idea of taking 3 beats is because usually in people who are healthy, 3 heartbeats to 1 respiration. That's sort of the general cycle that people have. So the idea is you're trying to account for respiratory variation or something like that. If you look intra-reader, so the same person making the measurement a month later, then their error is about half the error of the inter-reader. Which makes sense that if I make the measurement today and if I make that same measurement 1 month later, then I'm probably going to be consistent with myself because I'm going to make the same mistakes, right? Unless I learn something different or better. This is important because what this tells you is that if you want to make measurements that you can believe in and follow patients serially, then you need to have one person making the measurements and you need to have them repeat the measurement in 3 cardiac cycles and so on and so forth. So that would be ideal. If you look then at what the error was with different kinds of measurements. So here is area calculation based on 2 quantities, 3 quantities, 4 quantities. These are dimensions, like LVED is a dimension. These are time velocity integrals. These are slopes, like isovolumic acceleration is a slope. Okay. These are times and these are velocities on Doppler, and these are ECG kind of things. Higher error is worse. Okay. And what you see is that slopes are really, really bad. Okay, by way of their reproducibility. They may be a really good research tool, but if you're trying to figure out something that's reproducible, if between 2 readers, if you have a 40 to 50% variability of a measurement, I think you should not make that measurement. You're going to create a lot of confusion. If my weight varied by 40 to 50%, I would stop weighing myself. You know, it would be ridiculous. It needs a different scale. Okay. Just by the way, simple things like areas and calculations based on 2 quantities worked out quite well. And if you looked at which are these things that are really bad like that, it turned out that there were things like isovolumic acceleration for intra-reader and isovolumic acceleration for intra-reader. And also things like TAE index. TAE index, which is the MPI or IMP, or call it what you want. All right? So we don't use those measurements in our lab anymore. What measurements can you rely on the most? So the ones that have the least error. Some time intervals, some Doppler velocity kind of measurements, and simple diameter measurements, either 2D or on M mode, which is just fascinating. Traced areas. Okay. So simple measurements seem to make a lot of sense. So we concluded from our study that beat averaging improves both inter and intra-reader reproducibility. Intra-reader reproducibility is better than inter-reader reproducibility. And even it doesn't matter if you average 1 beat, 2 beats, or 3 beats, some variables are just terrible. They're really poorly reproducible, like slopes and some big calculations. So that's the first sort of part of my presentation. And then I'm going to go on to 3D part.
May I ask you a question about that?
Yeah.
Because of course it's obvious in simple things we manage well, and
Yeah.
the more complicated things we don't do as well.
Yeah.
Could you comment, could that also be slopes and more complicated maybe evaluations, that the reason we don't do that as well is because it hasn't been done, or you haven't been doing it as long?
Yeah. Sure. Yeah.
I don't think that's the reason. I think there's 2 things. In a slope, or then maybe 3 things. A slope, if you vary your slope just a little bit, the value changes a lot. The second thing is image quality. So if you look at a pulse tissue Doppler and you're trying to get isovolumic acceleration, it's often small, it's often not very clear, and the edge is jagged. So it's both difficult to define the line and you can change the slope. I'm sure you'd get variability, perhaps less than isolated acceleration, because that's particularly bad. But if you had to do the slope of the E-wave, if you use microwave deceleration time, you will get poor results, I'm sure of it, because you often get, you're not sure where that slope is, it's a bit fuzzy. That's a linear measurement, pay attention. You might as well be defining a dimension, but it's particularly because you're trying to go between, but it's, I'm saying it's linear.
We're talking about derivatives here. First and second derivatives are terrible things to try to measure by hand. If you get a good signal, you may have a machine that can do these things for you and do it well, but to try to do it by hand is very difficult.
Yeah.
You mentioned sweep speed, because if you're just looking at a slope, if you spread it out, you get a much better opportunity to make a measurement, and I don't think we do that a lot.
So what we did in this study was that basically all of the study personnel had to go to the core lab for a 2-day training session. And we were taught how to, whether it was directors of the local labs or the sonographers, we were taught how to make the measurements. So we did them in a way that was consistent with what was taught to us in 2005 to 2007. We were not taught to make all measurements on GE machines because not all of us have GE machines. We used whatever machines we had, and we sent in our traces based on whatever we had. But they were made use pulse wave and not using, we did not do color Doppler myocardial imaging.
If you taught incorrectly, if the sweep speed is slow, it doesn't matter what you taught.
Our sweep speed had to be at least 100.
At least 100. At least 100. So these are not slow sweep speeds.
No, our sleep speed, and what happened was that we were actually graded on the quality of the, there was some element of pride in making sure your quality was good. So we weren't trying to make it look bad, trust me.
Let me ask you just one other question, is that the ASE has recently, under the auspices of Dr. Cullen, suggested that M-mode measurements should not be made anymore.
Yeah.
We should make them by 2D.
Yeah.
And M-mode has got a sampling frequency of 2,000 times per second, and 2D, sometimes if you're lucky, can get 30 frames per second.
Right.
So you never know whether you're getting really end-diastole and end-systole.
Yeah.
Has anybody looked at anything like that?
Yeah, we're trying to look at it inside the study. Part of the problem is that we don't really have a gold standard inside this study. No patient had, patients did not consistently get MRIs or autopsies to figure out what their sizes were. So we don't. All we can do is look at the reproducibility of measurements. We can't really look at, accuracy of measurements, and so.
Was there a difference in dimension measurements between 2D and M mode?
Small, not systematic.
Yeah.
Was there a difference between like fractional shortening or rejection fraction?
Yeah, small but not significant. But I can tell you that of the 2D things, the thing that was most interesting was that the 5/6 area length method gave the most reproducible EFs and volumetrics for the LV. Not the biplane. No. They were obtained by the 8 clinical sites. The images were obtained by the 8 clinical sites. So, yeah.
Another barrier to this is that in large centers, scans are done mostly from sonographers who are very well trained and do only that.
Yeah.
So their measurements are mostly more accurate than physicians.
Yeah.
I think you're right about that.
Yeah.
That's been my experience, I'll tell you.
Yeah.
In Europe, mostly you will not find in many places sonographers. They don't exist as a specialty.
In Europe, yeah, right. No. When I was in Italy, I introduced the concept. There were a few up in the northeast, but in the rest of Italy, there were no sonographers, and we changed that. There are now.
And time consuming of the scan?
Yeah.
These parameters,
So,
what was the mean time?
Yeah, so the performance time for the study itself was actually about 20 minutes. But no measurements were made during the study. Only the images were acquired during the study. Okay? I personally made measurements on the studies that were done at MUSC. That was what I was supposed to do. It took me between 1.5 hours and 2 hours. a total of 900,000 measurements were made during the study. So yeah. Should I go on to this, or you want me to just stop? Okay, I can't talk about 3D echo, so there you go. Yeah, I'd love to. Sure. Sure. Sounds good.
5 minutes.
5 minutes.
For me, it's 2 minutes.
That's really funny. Okay. So here we go. So with 3D echo, the vision is that we have to have transducers for all sizes, capture full volumes of structures, get high frame rates and high spatial resolution, and that your volumetrics would be automated. That would be sort of a dream, that you get reproducible, fast measurements. I'm going to show you what you can quantify easily. So linear dimensions and traced areas, things like this can be quantified. And then we'll go on into LV volumetrics a little bit. So here's an example of how do you measure the tricuspid valve? How do you look at the tricuspid valve? And in many of the things that have come in so far, so for example, in pulmonary atresia, intact ventricular septum, or in critical PS, we would measure the diameter of the tricuspid valve and take it from there. One of the things that you can do with the 3D image is you can open up the volume you can open up this data in a quad screen display. So this is what's called a multiplanar reformatting kind of an image, and these are all orthogonal kind of views. 4-chamber, a 2-chamber, a short axis, and what we're going to do now is we're going to position these cursors. You see the blue cursor here? So the blue cursor is being positioned at the hinges of the tricuspid valve in the 3 o'clock view from an apical 4, and then in the sort of the 6 o'clock view at the same hinges. And when you position it that way, you see the tricuspid valve the way it really is. So that's the annulus of the tricuspid valve, the hinges. Okay? So the idea is that if you have something like this, then you're going to be able to get an actual area of the valve, as opposed to measuring a diameter which could be this or that or this, depending on where you measure it from. Okay? So maybe we'll get better with our ability to measure things. You can do the same kind of thing with regurgitant orifices for regurgitant jet. So for example, this is somebody with tricuspid regurgitation, and we're going to do the same thing. We're going to position our cursor so that it is perpendicular to the jet, and you're going to see the jet here the way it really is. So in this case, the narrowest part of the jet, the vena contracta, actually is like a linear kind of a thing because it's inside one commissure. It's central and inside the anteroseptal commissure. So you can magnify that up, and then you can trace the regurgitant orifice. So then you get a real area of the regurgitant orifice. Next, I'm going to go on to the recommendations that came out from the European and American Society of Echo for 3D image acquisition and display. So these are quantitation quantitation parameters that came out from the ASE with Luigi Badano, Roberto Lang, these folks. I was kind of fortunate enough to be part of this group. This came out in the January issue of JSE. And what the group recommends is it recommends 3-dimensional volumetrics for the LV over 2-dimensional imaging in adults, both by transthoracic and by TEE. And they say that the RV volumetrics have great promise but limited kind of current applicability and so on. This is a table from that paper. It looks kind of complicated, but I'm going to go over it with you. So these are the different things that you can measure: LV, RV, LA, RA, mitral valve, tricuspid valve, and so on. This is recommended for clinical practice, promising clinical studies, areas of active research, and unstudied. So you can see here that LV volume, LV EF, mitral valve anatomy and stenosis, and guidance of transcatheter procedures are the 5 things for which this panel recommends things. It's not surprising that these are primarily the things that the adult guys are interested in, but anyway. And then promising clinical studies for LV mass, also promising for RV volume and RV EF and aortic valve. But our things that we might be more interested in, like the tricuspid valve and other things, are not exactly part of this sequence, not yet. So I'm going to discuss with you the different options that we have for LV volumetrics. This first one is, and I'll tell you the names of the companies because there's no point holding them back. I don't get any money from the companies. I don't have any relationships with them. This one is from Philips. This one is a border detection kind of a modality. And what it does is it's based on landmarks. So what you have to do here is you have to kind of get a full volume apical 4-chamber view, and then you have these cursors, and again in this quad screen display you have to basically position the cursors so that they are going to bisect the ventricle in all these planes. So the red line bisects the ventricle into equal right and left planes, the blue line bisects into equal up and down, and so on and so forth. And after you do that, then you have to point to the mitral valve in these 4, so the 4 hinges of the mitral valve and the apical endocardium. And when you do that, the software will draw out the LV for you in 3 dimensions. And it will give you an end diastolic volume over there. You can adjust the contour if you don't like it. And then you do the same thing at end systole. And so after you're done with that, you get something like this. So you get a time volume curve for the entire ventricle as well as for subvolumes, and so on and so forth. You get an EF and all of that. You can do dysynchrony studies, but your frame rates are going to be not that good. And then you can do parametric imaging, so you can look for regional wall motion abnormalities, both in terms of times and excursion and so on. So sort of a report card. So this is a good thing because it's integrated into the machine. So you can make measurements on the fly. You do an echo, you can make your measurement. If the doctor is doing the echo, they can make the measurement right away. But the problem is it takes time. And it needs a lot of user input. So you have to learn the software, you have to learn how to do the thing, make these points and all of that. Next option is something that is using 2 different types of technology. The first one is border detection, just like we saw earlier. Plus, it uses 3D speckle-based automated analyses. This one is done by the TomTech people. And what this gives you is it gives you volumetrics, and it also gives you the ventricular strain in all 3 dimensions. Now note that you're going to be getting lower frame rates because it's a 3D volume. But this is more or less what it looks like. The software is actually very simple. You open up the data set, and it will immediately tell you, like you have to tell it that this is an apical 4-chamber or a subcostal long axis or whatever. As soon as you open it up, it's going to show you a quad screen, and it will tell you where it thinks various things are. So in this heart it says, I think the aortic valve is there, the apex is there, mitral valve is there, and so on. If it doesn't get this right, you probably should not proceed anymore, because now the software is confused. Okay? It better figure this out for you. And then once you do that, then you it gives you certain baseline traces. You can adjust the traces if you want. You have the ability to correct these contours in 6 different planes. And once you do that, you get a 3D volumetric picture of the ventricle, like that. Okay. So it's nice. It's easy. If your image quality is good, then it's really wonderful. It's just about automated. It's quick, and it's vendor independent. So you could get your images from it. Doesn't matter. Toshiba, GE, Philips, Siemens. It doesn't matter. As long as it's a 3D image, these guys will take it. Okay, and you get high-level function assessment also, which is kind of nice. But it is offline, so that means you may have one system to read your echoes, and then you have to have this other one to do your measurements, unless they are both integrated. To integrate them costs even more money. So then you're paying for one system plus another system plus for the integration. So, and it's new. So it's sort of validation has not quite been done yet. The third option actually sounds interesting, just in terms of principles. This is what's called a database-driven option. This is from Siemens, and it's not been released for pediatrics yet. So what this is you acquire your 3D image, and the system learns just by looking. The system learns it. System looks at the image and decides, okay, that's a left ventricle that's acquired, and so on. This is the shape of the ventricle. And it has a built-in database that has millions of sort of built-in points and things like that. So this is a new thing that's coming out in IT that is called machine learning. So the machines are getting to be kind of smart. And this has been validated in adults. And the beauty of it is that I've actually seen this where 6 different machines are being used. Everybody opens up the same data set, and you hit this analyze button, and everybody gets the same number. Because you're not analyzing, the machine's doing the analysis for you. So that's good. So it doesn't require user input, so it's quick, it's easy, it's automated, but there's no pediatric database yet, so that's a bit of an issue with it. So there are several approaches we've talked about with LV volumetrics, different methods, different vendors, and so on. The volumetrics have actually provided comparable results, and that's a paper that just came out last year from this group, which compared the volumetrics on the same patients by 3 different methods and so on. And those are their sort of comparison charts over here. So these are correlations between direct volumetric versus speckle, which means between QLab and TomTech, if you will, and they look pretty decent. On the other hand, there are 2 different vendors that do 3D speckle tracking for ventricular function. One of them is Toshiba and one of them is TomTech. And if you look at these guys, there's a lot of variability between the 2 measurements. There's more variability if you take the same machine to acquire the images and use different software. And there's less variability if you have 2 different machines and you use the same software. So if you take a TomTech machine, if you take a Philips machine and a TomTech machine, Philips machine and Toshiba machine, and you use TomTech software, you'll get less variability. But if you use 2 different machines altogether, you get into more trouble. So this is a big dilemma for us, not just in 3D but also in 2D echo. This is a nice research paper that came out talking about how to improve volumetric measurements, and they talked about these being the problems that exist for the newer technologies. The formats are proprietary. The companies don't want to give up something when they think that it's really good. There are varying amounts of compression of the images. The normal ranges are not established, and so on. Now, in 3D, there are limited pediatric transducers. In fact, right now there's only one. And the advances have really come in transducers and so on for adults. The software that has come out has primarily been for the left ventricle and the mitral valve. Our children tend to kind of move. The patients move. The hardware is moving because they have new machines that come out every year or every 2 years because the companies are just trying to catch up all the time. And the software changes because we don't like something, we kind of give the companies feedback, they improve it, it's better, but it's different. Sometimes it's not better, like we talked about yesterday with the right ventricle. And we have issues with the resolution of the images as well. Babies don't tend to hold their breath, and that's a problem when you're trying to deal with beats that are averaged over, where you acquire a beat over 3 to 4 cardiac cycles. This is Mark's paper that I talked about yesterday. This is looking at LV volumes by MRI versus by 3D echo, small LVs, and showing pretty good correlation. And what he noticed was that the EF tended to get kind of underestimated by 3D echo because of issues that may include trabeculation, frame rates, and that kind of thing through plane motion. A little bit about single ventricle volumetrics. We talked about the issues with the RV software, but just to show you where the technology was 4 years ago. So this is Brian Soriano. He was at that time a fellow at Boston Children's, and he did this study looking at children with hypoplastic left heart syndrome or with otherwise single ventricles who are also getting an MRI. These are the MRI volumes and these are the 3D echo volumes. It looked pretty good. And what he did was he used method of discs to make the comparisons. Method of discs by both MRI and by 3D echo. Method of discs by 3D echo is not available anymore. The EFs didn't match up particularly well, which is sort of unfortunate, but not, you know, it's reasonable. R value of 0.65, so it's not bad, but tells you some things. So some practical suggestions on how to get better with overall reproducibility of your measurements. First is to minimize variations. So minimize variations in sonographers. Dr. Sanders said that in Boston, for example, they have designated sonographers for given patients, that kind of thing. Minimize variations in your machine vintage because the IQ of the machine changes based on the vintage of the machine. So if you have a 10-year-old machine that's used to make especially one of these newer measurements, whether it's a IVA measurement or tissue Doppler thing or a 3D thing, you probably shouldn't use a 1-year-old machine and a 7-year-old machine at 2 separate visits. Probably not going to be the right thing. If you use a pediatric transducer at 1 visit, you might want to try to use the same transducer the next time they come in, especially if it's for a 3D kind of a thing or for anything that's high-tech, because the frame rate and other things also get affected based on the what year the transducer came out. And then the software package on the machine and on your EchoPax system. Averaging of cardiac cycles, I think, is a good idea. And that's the paper that I just sort of talked about. So in summary, there have been some significant advantages. We are pushing towards automating, towards speed, reproducibility, validation, and so on. I don't think I'm going to be allowed to take questions, but I'll try while Mark is coming up or something.
Thank you, which is great. Listen, it's 10 o'clock now, and we've just had an executive decision at the back of the hall that this session is so important that you need to listen to it. So what we're going to do is take a break for tea now, and we're going to carry on. A half an hour for tea, then Mark will talk then, and then we'll do Dr. Asmani after tea. But we're then going to have to decide what we want to scrap as sessions, and we decided that we take the last session, which is anomalies of inflow from the left ventricle to subaortic stenosis, and if we get a chance to do it, we'll do it. Otherwise, we're going to scrap that session and carry on with everything else. Subaortic stenosis and scrap it. Okay?
Okay, so Dr. Sanders spoke about the etiologies of cardiomyopathy, so I'm not going to repeat that. But just to summarize, I think the goals of functional imaging, which if you're imaging cardiomyopathy, that's functional imaging, is I just want to stress in infants with a dilated cardiomyopathy or with a dysfunctional heart, you have to look for an etiology that's repairable, and that's mostly an anomalous left coronary artery. So even though it's a minority of what you're going to see in the dilated hearts, when you see that with mitral regurgitation, especially in an infant, look for that. Ventricular volumes, ejection fraction, we talked about diastolic function and filling pressures. I think pulmonary artery pressures you should not forget, and we'll talk a little bit about right ventricular function. So even though these are thought to be left-sided diseases, they're not. They're two-sided diseases, and pulmonary artery pressures contribute to the right ventricular function. AV valve regurgitation, predominantly mitral regurgitation, is important. And then, as I said, the contralateral ventricular function, the right ventricle. We look at regional myocardial performance. I'll talk about that. We look at dysynchrony in certain patients We get the data on all cardiomyopathy patients, but we don't analyze it in all patients. We do it when the heart failure or electrophysiology service asks us to, because the analysis takes a lot of time. But it's easy to acquire those images and look for pericardial effusion. So I'm going to talk about dilated and hypertrophic cardiomyopathy and talk a little bit about other things from the previous speakers. I won't talk about non-compaction, etc. So, my task was to talk about tissue Doppler and strain. I want to emphasize that in cardiomyopathies, you don't need tissue Doppler or strain to diagnose that this is a cardiomyopathy. And the most important things are the physical examination and the history. And what we look for in the physical examination, that's what you're going to look for on your regular echo. And so it's not the strain imaging or the tissue Doppler imaging is not the center of the imaging. So I think New York Heart Association class or the Ross score or whatever you choose to use, hepatomegaly and dyspnea as measures of right ventricular and left atrial pressures, things like that on the physical exam correlate with what you're going to look for on echo, and those are the most important things. Cardiac third heart sound, if we're talking about diastolic dysfunction, etc. And I know this is an echo talk, but this is why I've brought these things. And you don't need fancy things in some studies to predict which patients are not going to do well. This is the cardiac thoracic ratio on chest x-ray. And if you decrease your ratio, you live. And if you don't, you die. And so those simple measures are more important than the things I'm going to talk about. Same for heart rate, and this maybe relates to what Norman talked about with the systolic-diastolic ratio. Ventricular volumes, I believe, are extremely important. It's interesting that in the pediatric data, there's conflicting data as to the prognostic outcome of end diastolic volume and systolic volume. But in general, if we take adult and pediatric literature and we think about it, ventricular volumes are directly related to the remodeling and the function of the ventricle. So I think that these are important, and Girish spent a lot of time on how we measure them and the problems, but these are also in some studies correlated quite well with outcomes. If you look at the predictors of death in terms of echocardiography, very interesting. Endocardial fibroelastosis, which you saw some pictures from the pathology specimens, but right ventricular failure at presentation. And this is a pretty consistent thing. So even though we're talking about left ventricular diseases, the right ventricular function is critical. So if you're reporting an echo, you have to report or you have to assess both the left and the right ventricles, and I'll come back to that in tissue Doppler. And here is work from Colin McMahon when he was in Houston some years ago. Ejection fraction and ventricular volumes predicted the outcomes of transplant death or cardiac hospitalization. I'll come back to his studies, as did right ventricular function. I'm going to skip this because Norman talked about the systolic to diastolic ratio and the normal data. We've also recently shown that mitral regurgitation correlates with outcome in children. It hadn't been previously shown, even though it seems in adults it's been shown, and even though it seems to be a simple thing. So assess the simple things first before thinking about the more advanced things. So moving to tissue velocities now. In dilated cardiomyopathy, don't know why this is not playing now, it did, but obviously, and some of the hearts that Norman did show moving, this heart does move, you don't need tissue Doppler to say that that's dilated cardiomyopathy and that's a dysfunctional ventricle. In general, your velocities are going to be very low. There's some regional variation, which I think may be important, but we don't use tissue velocities, or it's not quick enough unless you're taking color tissue Doppler to look at every region. But you can see that the septum, even though the velocities are very low, has a more organized contraction in this heart than the lateral wall. But in general, velocities are going to be low and they're going to be abnormal in their pattern. Now, here's color tissue Doppler. All of these move, and I'm not sure why they're not. I don't want to waste time. But this is color tissue Doppler. And again, I think you can start looking, if you want to go beyond the diagnosis and look a bit more at mechanics, and especially for research, you can see that there are regional variations. And you can see here that these tissues start moving together, but the lateral wall terminates the velocity of the lateral wall terminates before the septum here, and I think these create regional heterogeneities which probably reflect heterogeneity in the wall stress between various regions and contribute to the cardiomyopathy. Norman talked about assessment of diastolic function. I'm not going to show you data. We've done some interesting research which we've submitted for publication on how poor we are. Girish, we're even worse than your data in assessing diastolic function. So this is no trivial matter. It looks easy in the adult guidelines. I won't go into the details. We just poor both in the agreement between observers and in assessing both filling pressures and the grading of diastolic dysfunction. But at least by the guidelines, and we use this clinically, diastolic tissue velocities have a place in both the assessment of the severity and in the filling pressures. And Norman showed you this, and there was a comment from Steve at the back that they don't work that well in children, and that's correct. They don't work that well in children. I think one of the reasons is that these only work, the E to E prime ratio as a measure of filling pressures only works when there's when there's abnormalities of relaxation. And in children, interestingly, we hardly ever see abnormalities of relaxation as an isolated or as the first part of diastolic abnormalities as published in the adult guidelines. We almost always see elevated filling pressures in combination, even in hypertrophic cardiomyopathy, and I'll get to that. Only the minority of our patients had a delayed relaxation as the only abnormality. Nonetheless, the rationale for this measure is that as you increase your filling pressures, you get this phenomenon of pseudo-normalization due to what Norman said, that the E wave increases, but your tissue velocities don't increase. So to correct for that, you correct for a pressure-related phenomenon by a volume-related phenomenon, and that's why it reflects the filling pressures when you have the delayed relaxation. Whatever measure you use of elevated filling pressure, be it the E to E prime ratio, be it left atrial volumes, which in recent years has gained a renaissance of popularity, at least in the adult literature, or be it deceleration time, whatever, bless you, whatever measure you use, this is a poor prognostic sign. And that's been shown in adult data, and we've shown this as well in unpublished data. This is not yet submitted, that if you have a deceleration time less than 100 in our study, but obviously it's heart rate and age dependent, but a short deceleration time, that is a poor prognosis, and that's been shown in adults, especially in combination with a reduced ejection fraction or fractional shortening, one of the measures of systolic function. So if you have systolic dysfunction, which obviously you do by definition in this condition, and you have progressive diastolic dysfunction, your prognosis is not good. And just one of the things that we don't often talk about, that I've done some research on that may contribute to this, is diastolic dysynchrony. We talk a lot about systolic dysynchrony, and I'm not going to go into that because that's a whole topic and we don't have time, as you understand. But if you, a few years ago, we showed that if there is diastolic dysynchrony, you may have, this didn't quite reach significance, you may have diastolic dysfunction, and in the adult literature it's been shown to correlate with filling pressures, and that predicts outcome. And you can see that this is not uncommon in dilated cardiomyopathy. So looking in terms of prognosis at outcomes in dilated cardiomyopathy, I mentioned this study by Colin McMahon. You can see, as I said, that dilated cardiomyopathy tissue velocities are markedly lower than normals. But the things that predicted the outcome beyond the ejection fraction and right ventricular fractional area of change, which is a surrogate for right ventricular ejection, were the tissue velocities and especially the tricuspid lateral E, or the E prime. So again, a measure of right ventricular function in what we think of as a predominantly left ventricular disease, and the diastolic velocity more than the systolic velocity. And here's the data in the univariate and multivariate analysis. You can see that the tricuspid E velocity was useful. We don't throw out EF. Those are useful things in terms of prognosis. This is additional data. Now, systole and diastole are intimately linked. if you'll just allow me, I don't know why none of these, I think maybe it's because the folder is closed. I'm not sure why the folder isn't closed. So I'm not sure why these played until today. Sorry? Okay, well, I'm not going to reboot it now because I'll be a very unpopular man. But what? Sorry? Well, anyway, I showed this in the first lecture, so you've seen this model of the left ventricle with the systolic torsion and untwisting, and that's been shown to contribute to the creation of intraventricular pressure gradients in the left ventricle. And so that's why both systolic and diastolic function are important, because the one is connected to the other. They're not separate things. So your systolic function and the creation of torsional mechanics also releases the torsion in early diastole. And Norman showed you this study that we did of the mitral valve opening or the color inflow M-mode velocity that demonstrates that link. And we looked with tissue velocities at this in a number of cardiomyopathies. These are controls, dilated and hypertrophic cardiomyopathies, and whatever the condition is, these are just simple tissue velocities as one vector of that complex motion, and these are linked just to demonstrate that relationship. So that's a little bit about tissue velocities, and now I use them to think about cardiomyopathies. Clinically, we use them, we measure the peak velocities, and we follow that over time. That's what we do clinically, and we assess desynchrony in certain patients. As far as strain imaging or deformation imaging goes, there are quite a few studies that are coming out in the adult world about prognosis. And what I wanted to show you in this slide is, first of all, Tom Marwick's group, he's now in the Cleveland Clinic, but from Australia, originally has proposed this global longitudinal strain. So the global strain is the averaging of multiple segments. Okay, and usually if you're just doing longitudinal strain, usually people are just doing it in the 4-chamber view, so it's six segments, even though you could average strain over more segments. And you can see that if the strain is less than -7 in this study, and this value repeats itself in a range over various studies, you can predict worse outcomes. So this may be useful in addition to the ejection fraction. In most studies, they looked at the additive value of this. And what I want to show you from this, obviously, the strain values here are much, much lower than if you remember when we talked about mitral regurgitation, and if there's time, I'll talk about aortic regurgitation. In regurgitant lesions, even though you've got a dilated ventricle, the minute your strain goes less than normal values, essentially, less than -19, -18, for longitudinal strain, your prognosis worsens. In cardiomyopathy, obviously, you've got to go lower than quite abnormal values, -7 for global strain. The other thing global strain does is that it reduces the variability of strain measurements, which are even more of a problem than just the linear dimensions that Girish talked about in the last lecture. And we've used strain to show that there's a connection between the time that it takes to get to peak strain and the peak strain developed in both cardiomyopathies, dilated cardiomyopathy, and normal. So that's in terms of dilated cardiomyopathy. I want to move on to hypertrophic cardiomyopathy, and you saw a very similar slide from Dr. Sanders. And indeed, sometimes when you just look at this heart by 2D, there is a correlation in some of the genotype-phenotype relationships. This is the most common pattern of the so-called reverse curvature and corresponds with some of the most common genes responsible for the hypertrophic cardiomyopathy. So we don't use this as a prognostic factor, but if you had to cluster these, they do have prognostic value. In terms of what we use echo for, you've heard from the previous speakers, but the ASC guidelines summarize this, and echo is the recommended imaging modality, certainly as the initial test for ventricular and wall thickness, for systolic function, for filling pressures, pulmonary artery pressures, left atrial volume, and again, filling pressures. If there's dynamic obstruction, mitral regurgitation. In adults, they look for ischemia. And Rarely MRI, and I'm sure Karen will speak about this, is used for fibrosis imaging. Simple measurements like M-mode and 2D for wall thickness are very important in terms of prognosis, and you saw some hearts. I think that these are some of the most difficult measurements to make actually in patients, and these are not a trivial measurements. We always just say M-mode or 2D for wall thickness. It's sometimes very difficult to define what that wall is, what's right ventricular trabeculations. There can be abnormal LV muscle bars, etc., that make this measurement quite complicated. And to do it the same way in serial visits is another challenge. We use bicycle echo to elicit gradients in patients that don't have gradients at rest and that the clinician thinks there might be some component of dynamic outflow obstruction. So we have an exercise bike protocol, and sometimes you see quite significant gradients in these patients from systolic anterior motion and dynamic outflow tract obstruction like that Norman showed you beforehand. Okay, so there's definitely something wrong in my linking because all of these work, but that's just to show speckle tracking actually. I do want to show this, so I'm just going to go out of the I'll come back to similar. I just want you to see the patterns here. What you see here, maybe it will play if I just do it like this. It's lost its link somehow. Yeah, I need to reboot or something. All of these work. But if you look at the patterns over here, you can see very reduced septal strain, which corresponds to the septal hypertrophy. And during bicycle exercise echocardiography, this area does not increase its strain compared to other areas, which also have abnormal response, so that you get an inadequate response in myocardial performance at peak exercise versus normal. Now, tissue Doppler in hypertrophic cardiomyopathy can be highly abnormal depending on what's going on with the tissue and what region of the heart you're in. So here you can see a patient with quite marked septal hypertrophy. This was an interesting patient, one of twins. Both of them they looked similar, and they almost had a very, very similar heart. They were actually from Serbia and had moved to Toronto. And you can see very abnormal tissue velocities, but differences between the mitral valve and the septum with low and reversed EA velocities at the septum, a long diastolic period, and you can see with the blood Doppler a very prolonged relaxation time. So this is one of the conditions where we may see predominantly abnormal relaxation in children, and the tissue velocities will help you there. We don't often see it outside of this situation. Look at the tricuspid valve. It's also abnormal, and you saw that there's involvement of the right ventricle. I can't always explain tricuspid abnormalities. Like someone asked me about chemotherapy and how we use tissue velocities. Sometimes I see abnormal tricuspid velocities in chemotherapy, where otherwise the right ventricle looks okay. I'm not always sure what that means. One of the things that's important, I said, is to evaluate the filling pressures in hypertrophic cardiomyopathy. And we talked about the E to E prime ratio, and here you have delayed relaxation. It's a problem to use the E to E prime because, remember, you're using a local velocity to reflect on a global phenomenon, filling pressure. But if you've got variable diastolic velocities because of regional heterogeneity in the disease, you cannot extrapolate to a global phenomenon. So you've got to be careful of that. And here's an example where you might have OK at the lateral annulus, but the septal velocities will be low. But nonetheless, Colin McMahon showed that a decreased E-wave velocity and an increased E to E prime ratio in children is a prognostic sign of a VT or sudden cardiac death, and is inversely related to exercise capacity. So we evaluate that, but you've got to take that into account, that this is a heterogeneous disease, and we're looking at local phenomenon which may be different from region to region. So one of the important things, I think, in measuring filling pressures is to look at left atrial volumes, and this is recommended in the guidelines that Norman mentioned beforehand from the ASC. And This does correlate with the degree of diastolic dysfunction, at least in this pediatric paper from the Mayo Clinic. And in adults, left atrial volume in almost, or in many conditions, including this one, has been shown to correlate with outcomes, as I said beforehand, because it reflects your filling pressure. So at presentation, if you've got elevated left atrial volumes, your prognosis is certainly worse. Yeah, so same phenomenon. You get patients like this, sorry, it's not playing, where you get a relatively small ventricle and the large atria, like Norman showed you beforehand. So you might think that this is restrictive cardiomyopathy. But if you measure wall thickness, and you can see that the wall here, this is systole, so maybe not that easy, but I think everyone can see that the wall here is also thick. There's a subset of these patients that have hypertrophic cardiomyopathy with a restrictive phenotype. And here's an example from our lab, the patient that I showed you the 2D beforehand. Look at the E, high E. There's actually no A wave over here. The sonographer measured this as an A wave. This is actually an L wave, which I also saw on many of Norman's Doppler slides. It's a mid-diastolic wave, and you can get this by blood Doppler or by tissue Doppler, and I think you see it over here. And that's also a sign of increased filling pressure. So here there's a very short deceleration time, a very high E to A ratio. In fact, you don't even see an A wave over here. An L wave, you have a normal or shortened isovolemic relaxation time, because here it's reflecting that balance between delayed relaxation and increased filling and very abnormal tissue Doppler. So I think restrictive physiology and using tissue Dopplers and regular Doppler and just the 2D to look at the left atrial size is very important. These patients have poor prognosis or worse prognosis than just regular hypertrophic cardiomyopathy, and it's not uncommon to see that variant. And this is an adult study showing the vast difference in the prognosis between these groups, and this is in adult patients. Now, tissue velocities have also been helpful to look for abnormalities, because we all follow family members of these patients or relatives that have a gene positive but have not yet developed hypertrophy. And you can see that tissue Dopplers may be helpful. There's obviously overlap between populations, but here's the patients that are gene positive and have hypertrophy. They have very low tissue Dopplers, both systolic and diastolic. This isn't only a disease of diastole, as it was often taught, or perhaps in medical school. Here are the normals that have normal tissue velocities, and here is this intermediate group that have the gene for the disease but have not yet developed hypertrophy. So if you follow this serially over time, I think that can lead or can aid in early detection of the disease. And these slides are actually added in sitting at the back after your question on how do I differentiate athlete's heart from hypertrophic cardiomyopathy. There's certainly research to suggest that you can use both tissue Doppler and strain imaging for this purpose. And this is from Alan Fraser's work from Wales. You can see 4 different groups. Hypertrophic cardiomyopathy and hypertension are both going to have abnormal velocities, reduced velocities, and you can see in the hypertrophic cardiomyopathy a low E wave. And there's a low S wave as well, by the way, and I'll show you the summary of the data. But if I had to choose one, if you choose an E wave and you've got a low E wave, an athlete, a healthy adolescent athlete should not have an E wave less than 8. If you just want to use one cutoff. There are obviously tables, and I showed you normal data, but if you just want to use that as a rough cutoff. Whereas the normal, you can see good motion above 10 here, and the athlete has even more vigorous tissue velocities. If you translate this into deformation, even in terms of systolic deformation, you're going to get similar results. So here's still the pulse tissue velocities. This is the systolic wave. So here's hypertrophic cardiomyopathy. Here's hypertension. Both are reduced. There was no statistical difference in these groups. And here is the athletes. You've got to be careful. Nothing is 100%. You can't use this as an absolute, but it certainly can help. And by the way, Norman mentioned this between strength-trained and endurance-trained athletes. There there weren't many differences, at least in the tissue velocities. I'm not talking about the the chamber dimensions and wall thickness. So a few of the parameters that you may use, and I just added this on following the question, and it's often a debate, is concentric or eccentric hypertrophy in the athletes versus the asymmetric, which is more common, but not 100%. I showed you the percentages of the different phenotypes in the beginning. The wall thickness is usually less than 15 millimeters, even if it's a big adolescent. You may get a large LV chamber in the athletes, but the left atrium should not be enlarged. You should not see diastolic abnormalities. Your tissue velocity should be normal, and I'll add that strain should be normal as well, and you can just use longitudinal strain for that. And you should not see on MRI fibrosis or delayed enhancement. And if you stop training, there should be some regressions. I think in this field, tissue Doppler and strain imaging are helpful. In terms of strain, here is work from Javier Ganami when he was in Leuven looking. This is the pattern I showed you before that didn't play, but you can see very reduced septal velocities. So if you think a patient, if the septum is thicker, the lateral wall, and you do a longitudinal strain by speckle tracking, or these are by tissue velocities, you'll see reduced strain. I'll show you another example of that in the septum there. It becomes more difficult if you have concentric, or if you have symmetric, I should say, hypertrophy, but you'll get reduced strain in the abnormal areas versus the athletes who should have completely normal strain. And this correlated with the wall thickness. So the thicker the wall, the worse the strain, and that correlated with outcome of ventricular tachycardia or other adverse events. Here's another way to discriminate these patients using systolic strain. Here is the septal thickness divided by the posterior wall thickness. Here is the strain. And you can see in the black dots are the patients that had hypertrophic cardiomyopathy. Here are the athletes or that just had I think this was hypertension. These are athletes that had LVH. And you can see that normal strain versus the hypertrophic cardiomyopathy, and in those hypertrophic patients that had normal strain, because you will get always some patients like that, no test is 100% discriminatory, the wall thickness was abnormal in terms of the septal to posterior wall ratio. So these are all things that may aid, even if they don't give you a 100% diagnosis. Okay, these we know won't play already, so maybe I'll get them for another time, but I wanted to show you just these strain patterns. These are from patients in our lab. One of the nice things about hypertrophic cardiomyopathy, if you haven't done strain imaging before, these are easy to track. There's a lot of myocardium, there's a lot of speckle. It gives you a great feeling. Put the dots there, the software will track it, and that's where you should start, just to feel that you're getting successful strain curves. And you really do get nice strain curves, and you can see, this is, you don't need to be any expert to see that there's highly abnormal strain here. There's hardly any deformation at all. Sometimes you get some deformation with post-systolic shortening. And if you put this on and you've got a mildly thick septum, or you've got a very thick septum, such as in this patient, you will get abnormal strain, very abnormal strain rate. Can you see this over here? I'm not sure if you can see from the back. This is normal strain rate. This is going even in the reverse direction. There is no development of deformation in those segments, and radial strain, these segments are low as well. In fact, we may want to go to combining the data that Dr. Haspani will show you now with strain imaging to show regional abnormalities that correlate with functional abnormalities, and you can see that very nicely over here. And Bart Bainens has suggested that you can use the strain pattern. I don't think so much for pediatrics, and it's not specific enough, but the different types of disease may give you different strain patterns where you can start to differentiate. I'm going to skip over this. This is just work showing that genotype variations may influence the strain, regional strain, but this actually shows you again that very abnormal septal motion, lack of development of any deformation in those segments. So for hypertrophic cardiomyopathy, start with the simple things, the septal thickness, the pattern of hypertrophy. You can If you don't have outflow obstruction, we use exercise, look for microregurgitation. We talked about diastolic function, especially looking for restrictive physiology, right ventricular pressure, look for the systolic function. If you have markedly decreased systolic function, you might be in the burnt out phase of hypertrophic cardiomyopathy, a poor prognostic sign. And we use tissue Doppler and deformation in the ways I showed you, although they're not part of the current guidelines. Thank you, and I'm sorry the videos didn't work. Are we going for a break now? Yeah. Okay, I have to show this then. I'll take 38 seconds, not from your time, for coffee. I'll switch off the mic for this, okay? It's not on the video. So the other day